Good morning, everyone. Thank you, ISOO, for hosting this important meeting in Kenya and for inviting me to speak on international patient care. I am so sorry to not be present with you in this beautiful country where my father was born and raised. My father, John, was diagnosed with bilateral RB in Nairobi in 1946. Multiple Mzungu doctors missed his leukocoria. The diagnosing Kenyan doctor never used the word cancer. He simply said, "This cannot be treated in Kenya, you must go to England." And so my father became the first international patient I ever knew. 7 years after he died from a second cancer, I met Ratty, a little girl with extraocular unilateral RB after delayed diagnosis and incomplete care in Botswana. Ratty travelled to Canada for treatment that gave her the best last chance, but it came too late. She died on August 21st, 2006. 3 months later, Brenda Galley and I travelled to Kenya for the first time. We are all gathered here in part because of Ratty. Working with World Eye Cancer Hope, I receive frequent appeals for help to seek international care. In their quest for the best treatment, families increasingly look far afield due to limited local therapies or expertise or trust in them. The journey is complex, and for too many families, the outcome is worse than might be achieved closer to home. I note recurring challenges that influence care, coping, and outcomes. Broadly, these are the family's ability to access and understand information about RB and relate it to the child's specific situation, delays in starting treatment, the ability to fund treatment and follow-up care, poor communication and collaboration between local and international treatment teams, and inadequate psychosocial support at all stages of care. The internet helps educate about RB, but misinformation and sensationalized stories can cloud judgment, causing families and their supporters to reject recommended treatments, particularly enucleation. Removing an eye is a lifesaver, not a failure. Perhaps care begins with the language we use to describe RB treatment. Due to communication gaps and limited counselling, families often misunderstand the urgency of treatment and what is involved. More than 50% of families we assist ultimately require enucleation either at the international centre or back home. Those delays kill children. Securing international care is complex, time-consuming and expensive. Treatment begins fastest when funded by insurance or government, though they may only fund initial costs, complicating ongoing care. Self-funding can introduce months of delays. The bureaucratic web of travel documents and planning also delays care. Most families are unprepared for the duration and cost of living near the international treatment centre. These burdens, coupled with limited knowledge of retinoblastoma and its treatment, can lead families into a devastating morass. Families in high-income countries may more readily settle early medical bills, but the full cost is still onerous. Most families in lower-income countries struggle with fundraising, paper chasing, and misconceptions about available aid. International care can cause financial ruin. All children need meticulous follow-up care, especially after eye salvage therapy. Poor planning and communication gaps can lead to inconsistent, even totally absent follow-up care. Many families who contact We See Hope believe this to be optional, and the financial cost is beyond them. Self-funding families are at greatest risk of sinking into unrecoverable debt at this point, especially if they have already borrowed money or sold income-generating property to pay for treatment and related costs. Many families seek care independently, reducing the prospect of a realistic follow-up care plan. Lastly, international travel separates families, causing intense stress. Conflict and delays can occur when the parent left behind is not included in consultations. Cultural and language differences magnify feelings of isolation and loneliness. Sometimes feeling unsupported and overwhelmed. Families abandon ongoing care. So how can we improve international care in these 5 domains? 1. Providing information. Please educate parents about RB, recognising their shock, denial and fear about cancer, blindness and mutilation from surgery. Communication should be clear, consistent and involve a translator if necessary. Explain the impact of untreated cancer and the risks of delaying care. Emphasise that enucleation remains possible even with eye salvage therapy and the importance of follow-up care. Be clear about all costs involved, available funding support, and collaborative local care options. Please be aware that We See Hope cannot fund individual patients. Repeat often. Stressed people don't hear and forget easily. It is better that families hear this information often and from multiple sources than not at all. 2. Collaboration for local care. How can you work together, local and international centres, to treat the child and support the family's financial, mental and physical health and unity? Can you collaborate to support local enucleation and pathology? Can telemedicine guide the child's care? Is referral appropriate to a regional centre with eye salvage therapies that will avoid the high cost of distant travel? And if so, how can you support the family to trust that recommendation? 3. Financial situation. Recognise that self-funding families have the highest risk of treatment delays. Identify the funding mechanism for all treatment and follow-up care before accepting the international patient. These are uncomfortable questions, but critical to sound treatment decisions. If international care is truly the best option, please support the family's fundraising and help to reduce their financial burdens. 4. Follow-up care. Working with a local centre early aids smooth care transitions. Develop a joint follow-up care plan wherever possible and ensure the family has a complete copy of the child's medical record to aid local follow-up care. If collaboration isn't possible, how will you and the family navigate the costs and logistics of follow-up care? 5. Psychosocial care. Use teleconferencing tools to include both parents and other key family decision makers in consultations. Offer a welcome buddy who can give orientation and emotional support. This person will ideally speak the family's language and may be a fellow RB parent or other volunteer. A welcome buddy at the local hospital can help parents feel less alone and overwhelmed and more confident in local care. International care can save children's lives and eyes when specialised treatment is unavailable locally. But desperate families rarely think rationally about the challenges and long-term implications. Medical professionals, hospital administrators and other advocates must communicate these realities, remembering that yes we can does not mean yes we should. Transparent, sensitive discourse about the urgency of treatment, viable options, costs, finances and logistics can inform good decisions for the child. We must do our best to ensure that proposed treatment also protects the sustainability of the family on which the child and other children depend. When everyone works together, outcomes improve for both the child and family with fewer burdens along the way. Collaboration also supports efficient use of limited resources and nurtures global expertise, raising better care for more children. My talk is based on an in-depth article We See Hope published in 2020, which includes many patient stories. You can read it at bit.ly/IRBcare. My father, Ratty, and other children like them inspire us daily. Together, we can change their stories from struggle to survival and hope. Their lives, their future, and their family's future depends on it. Thank you.